Hamstring injuries are among the most common injuries faced by athletes, but most people are familiar with strains that occur higher up in the muscle. Distal hamstring injuries, those that happen closer to the knee, are much less common and often misunderstood. This video will explore the anatomy, causes, diagnosis, and treatment of distal hamstring injuries, helping you understand why these injuries matter and how they can impact athletic performance. Whether you're an athlete, coach, or healthcare professional, understanding these injuries is crucial for proper management and recovery. Let's begin by looking at what makes distal hamstring injuries unique. Hamstring muscle group is made up of three muscles: the biceps femoris, semitendinosus, and semimembranosus. These muscles run from the pelvis down to the lower leg, crossing both the hip and knee joints. The biceps femoris has two heads, a long and a short, with different points of origin and insertion. The semitendinosus and semimembranosus are located more medially, while the biceps femoris sits laterally. Understanding this anatomy is essential because the location of injury, whether medial or lateral, can affect symptoms and treatment. Each muscle plays a unique role in knee stability and movement. Distal hamstring pathology refers to problems that occur below the myotendinous junction near the knee. Unlike the more common proximal injuries, distal injuries can be acute or chronic and may present on either the medial or lateral side of the knee. These injuries include strains, avulsions, and chronic conditions like snapping tendons or bursitis. Because they are less common, there's less research and fewer established treatment protocols for these injuries. Recognizing the specific location and type of injury is key to effective management. Distal hamstring injuries often occur during activities that involve sudden hip flexion and knee extension, such as sprinting, jumping, or kicking. These rapid movements put significant stress on the hamstring tendons, especially in sports like soccer, football, and track and field. While most injuries are non-contact, high-energy trauma can also cause avulsions, particularly in the biceps femoris. Understanding the mechanism of injury helps in both prevention and diagnosis, as certain sports and movements carry higher risks. Athletes with distal hamstring injuries may report a sudden pop in the back of the leg, followed by pain, stiffness, and weakness. Swelling and bruising around the knee are common, and in some cases a palpable mass or defect can be felt. Specific symptoms often depend on which tendon is involved and whether the injury is acute or chronic. Medial injuries may present differently from lateral ones, and chronic conditions like snapping tendons can cause popping sensations or instability. Diagnosing distal hamstring injuries starts with a thorough physical exam. Physicians look for tenderness, swelling, and defects near the knee. Resisted knee flexion tests can reveal pain or weakness, and comparing the injured leg to the uninjured side helps identify subtle differences. Neurologic exams are also important, especially for lateral injuries, as the common peroneal nerve may be affected. Complete ligamentous exam is recommended if a multiligament knee injury is suspected. Imaging plays a crucial role in confirming the diagnosis of distal hamstring injuries. MRI is the gold standard, providing detailed views of tendon tears, retraction, and associated injuries. Dynamic ultrasonography can be helpful for chronic conditions like snapping tendons or friction syndromes. While X-rays are less useful for soft tissue injuries, they are important for ruling out bony avulsions, especially at the fibular head. Choosing the right imaging technique ensures accurate diagnosis and guides treatment. Biceps femoris is the most commonly injured tendon on the lateral side of the knee. Acute injuries often occur during sports involving rapid acceleration or kicking, such as soccer and track. These injuries can range from strains to complete avulsions, sometimes as part of a multiligament knee injury. Isolated avulsions, though rare, can significantly impact an athlete's ability to return to sport due to the biceps femoris's role in knee stability and flexion strength. Low-grade strains and partial tears of the biceps femoris without tendon retraction are usually managed conservatively. This involves rest, physical therapy, and gradual return to activity. However, high-grade partial or complete avulsions often require surgical repair, especially in athletes. Studies show that surgical intervention leads to higher rates of return to sport and lower recurrence compared to non-operative treatment. Early surgery within 2 weeks of injury is recommended for optimal outcomes. Surgical repair of distal biceps femoris avulsions involves reattaching the tendon to the fibular head, often using suture anchors. The procedure may require a curvilinear incision, and care must be taken to identify and protect the common peroneal nerve. Postoperative protocols typically restrict knee extension initially, with gradual progression to full motion. Outcomes are generally excellent, with most athletes returning to sport within 16 weeks and low rates of complications or recurrence. The medial side, the semitendinosus, is the most frequently injured tendon, though such injuries are rare overall. These injuries often occur in high-level athletes during sprinting or sudden knee hyperextension. Patients typically report a loud pop, sharp pain, and may notice a lump in the back of the thigh. Distal semimembranosus injuries are even less common, but can have significant implications for knee stability. Diagnosing medial distal hamstring injuries involves careful physical examination. A palpable mass or defect is often present, especially with semitendinosus ruptures. Weakness in knee flexion and pain with passive extension are common findings. MRI is highly accurate for confirming the diagnosis and determining the extent of injury. Ultrasound can also be useful, particularly for chronic or snapping conditions. Early and accurate diagnosis is vital for planning treatment. Complete distal semitendinosus ruptures in athletes are usually treated surgically, as non-operative management often fails to restore full function. Surgical options include direct repair with suture anchors, tenodesis to the semimembranosus, or excision of the tendon stump. Postoperative protocols are similar across techniques, with most athletes returning to sport within 2 to 5 months. Early surgical intervention leads to better outcomes and faster return to play. Distal semimembranosus injuries are exceedingly rare, with limited evidence to guide treatment. Complete tears are typically managed with direct surgical repair, while partial injuries may initially be treated conservatively. However, delayed surgery or non-operative management often results in poorer outcomes, likely due to the semimembranosus's important role in knee stability. Early recognition and intervention are key for optimal recovery. Pes anserine bursitis is the most common chronic medial distal hamstring condition. It involves inflammation of the bursa located between the pes anserine tendons and the medial tibia. Patients typically present with medial knee pain, especially during activities like climbing stairs or rising from a chair. Diagnosis is clinical, based on tenderness over the pes anserine insertion and pain with resisted knee flexion. Treatment is usually conservative, including rest, ice, NSAIDs, physical therapy, and sometimes steroid injections. Napping medial hamstring syndrome is an uncommon condition where the pes anserine tendons subluxate or snap over the medial tibia. Patients experience pain, popping sensations, and sometimes instability during knee movement. Diagnosis is primarily clinical, but dynamic ultrasound can help identify the involved structures. While physical therapy can be tried, most cases eventually require surgical intervention, such as tendon release or excision, to resolve symptoms. Chronic or overuse injuries of the lateral knee involving the biceps femoris are rare but can occur, especially in young athletes. Symptoms include lateral knee pain and sometimes snapping sensations. Conservative management with rest, anti-inflammatories, and physical therapy is usually effective. If symptoms persist, surgical debridement and repair may be considered, often resulting in excellent outcomes. Napping biceps femoris syndrome is a rare condition where the distal biceps femoris tendon snaps over the fibular head during knee movement. Patients may report lateral knee pain, snapping, or instability. The most common cause is an abnormal tendon insertion, but fibular head hypertrophy can also contribute. Dynamic ultrasound is the best imaging tool for diagnosis. Surgical reattachment of the tendon to the correct location on the fibular head is the preferred treatment. In evaluating distal hamstring injuries, it's important to consider other possible causes of knee pain. Conditions like infection, gout, meniscus tears, ligament injuries, and cysts can mimic hamstring pathology. A thorough history, physical exam, and appropriate imaging help differentiate these conditions and ensure accurate diagnosis. This approach prevents unnecessary treatments and improves patient outcomes. Most distal hamstring injuries, especially low-grade strains in chronic conditions like bursitis or tendinopathy, respond well to conservative management. This includes rest, ice, anti-inflammatory medications, physical therapy, and gradual return to activity. Physical therapy focuses on strengthening the surrounding muscles and improving flexibility. Conservative care is the first line of treatment, unless there is a complete avulsion or failure to improve with therapy. Surgery is indicated for complete tendon avulsions, high-grade tears with retraction, and chronic conditions unresponsive to conservative care. Early surgical intervention, ideally within 2 weeks of injury, leads to better outcomes and faster return to sport. Surgical techniques vary depending on the tendon involved and the type of injury, but the goal is always to restore function and stability to the knee. Rehabilitation after surgery for distal hamstring injuries is crucial for successful recovery. Early protocols often limit knee extension to protect the repair, with gradual progression to full range of motion. Physical therapy focuses on restoring strength, flexibility, and function. Most athletes can expect to return to sport within 2 to 6 months, depending on the severity of the injury and the type of repair performed. With appropriate treatment, most athletes recover well from distal hamstring injuries. Surgical repair of acute avulsions has high rates of return to pre-injury activity, especially when performed early. Chronic injuries or delayed surgeries may have longer recovery times and slightly lower satisfaction rates. Conservative management is effective for most chronic conditions, but persistent symptoms may require surgical intervention. Preventing distal hamstring injuries involves proper warm-up, stretching, and strengthening of the hamstring and surrounding muscles. Athletes should focus on flexibility, especially in sports with rapid acceleration or kicking. Addressing muscle imbalances and ensuring adequate recovery between training sessions can also reduce risk. Coaches and trainers play a key role in implementing preventive programs. Imaging is not only important for initial diagnosis, but also for monitoring healing and detecting complications after surgery. MRI can assess tendon integrity and healing, while ultrasound can evaluate dynamic function and identify persistent snapping or friction syndromes. Regular follow-up ensures that recovery is on track and allows for timely intervention if problems arise. Complications from distal hamstring injuries or their treatment are uncommon, but can include nerve injury, persistent weakness, or loss of knee motion. Delayed surgery increases the risk of scar formation and nerve tethering, which can cause numbness or weakness. Careful surgical technique and adherence to rehabilitation protocols minimize these risks and support optimal recovery. Turning to sport after a distal hamstring injury requires a gradual, structured approach. Athletes must regain full strength, flexibility, and confidence before resuming competition. Functional testing and sport-specific drills help ensure readiness and reduce the risk of re-injury. Communication between the athlete, medical team, and coaches is essential for a safe and successful return. Elite athletes may face unique challenges with distal hamstring injuries, including higher demands for rapid return to play and increased risk of re-injury. Surgical intervention is often preferred for complete ruptures, and rehabilitation protocols may be more aggressive. Close monitoring and individualized care plans are necessary to meet the specific needs of high-level competitors. Distal hamstring injuries are less common than proximal injuries, resulting in fewer studies and less robust treatment algorithms. Ongoing research is needed to better understand the best management strategies, especially for rare injuries like distal semimembranosus tears or snapping syndromes. Advances in imaging, surgical techniques, and rehabilitation will continue to improve outcomes for these challenging injuries. Still, hamstring injuries, though rare, can have significant impacts on athletes. Early recognition, accurate diagnosis, and appropriate treatment, whether conservative or surgical, are essential for optimal recovery. Understanding the unique anatomy and mechanisms of these injuries helps guide management and prevent misdiagnosis. With proper care, most athletes can expect to return to their previous level of activity. Stay informed and proactive to ensure the best outcomes for yourself or your athletes.